In this lecture, we're talking about diabetes as it pertains to eye disease or diabetic retinopathy. So whether you're a technologist looking to get some more information about diabetic retinopathy, or whether you're a patient that's just starting to show some of the findings of it, then this video is a broad overview about some of the topics of diabetes as it pertains to eye disease. In this lecture, we're going to be talking about general overview of diabetes in the eye. So a lot of people ask, why do I have to get my eyes checked every year? I have diabetes. Well, this is the reason. Over years, diabetes begins to damage the eye, and this is called retinopathy. And interestingly, it always happens in a very specific order. So we can almost predict what will be the next stage as the disease gets worse, because it's always a slow progression through time. So we're going to start from the very beginning of the disease and then end up in the most severe cases talking about what are the clinical features and then some of the treatment. Everyone ready? So a lot of times you look in the eye and there's no diabetes at all. It looks completely healthy. So we would call that diabetes without, maybe we'll just do an S. Sine, remember that from our other lecture on the eye. The S means sine, like sine correctione, without diabetes without diabetic retinopathy. So that's great. If you see a patient, they don't have retinopathy, wonderful. You can just have them come back in a year for regular screening. But even if they don't have retinopathy, there are moments when their glucose levels are high, and increased glucose will then lead to an increase in glycosylated end products or damage, and the part of the eye, actually your whole body that is damaged when there's increased glucose, is the vascular endothelium begins to be damaged. So if we look at, let's say, our capillaries as they go through our body, if you remember, there are tiny little cells that line the inside and the outside of our vascular capillaries. There are little red blood cells that kind of circulate through here too. You've seen photos of these. So all of our capillaries have little cells that line and give it both support and structure. So when the glucose is high, we start to see vascular damage. And the very first feature, this is not really seen clinically, this is seen on histology, is we begin to lose pericytes. So loss of pericytes. When there's loss of pericytes, are these cells on the blood vessels and capillaries. The loss of pericytes will then cause a weakening to the capillaries. We can't even see this clinically. So diabetes without retinopathy, they probably have some issues going on. We just can't clinically see any of it yet. But after a time, if you lose enough of the support for the capillaries, now we're going to have weakened capillary cell walls, and we're going to see the blood vessels starting to bulge. So let's say this is our capillary, and it's going to bulge. And this bulging of a capillary is called a microaneurysm. Microaneurysm. When you're documenting this in an examination, we don't like to write microaneurysm. It takes too long, so we write it as lowercase a, lowercase m, or MA for short. That means microaneurysm. You might have a few MAs on the blood vessel section. So that goes back to our lecture on documentation. MAs mean, hey, there are visible or clinical findings that show there's not just a little bit of diabetes, but there's enough that we can visibly see it. This is the first clinical stage diabetes that we can look in someone's eye and say, hey, you've got diabetes. Sometimes we'll see someone, they don't even know they have diabetes, but we look in their eye and if we see a few of these microaneurysms, we say, oh my goodness, you've got microaneurysms. That is the first clinical feature of diabetic retinopathy, or DR, or to be more specific, non-proliferative diabetic retinopathy. The very first feature is we start to see these microaneurysms. So interestingly, most people with mild NPDR and a few microaneurysms have zero symptoms, and there's really nothing you have to do to treat these except warn them about it, educate them about the importance of blood pressure and glucose control. On your clinical examination, we're going to just draw our picture of the eye. We are going to see tiny little red dots on examination. Those little tiny red dots represent these microaneurysms that you can see clinically. So we're looking at the blood vessel, and there'll be an outpouching or aneurysm off of it. That's NPDR. Let's pause this so I can erase the board and start our next section. So, over time, as the eye starts to develop more and more microaneurysms, let's do our diagram up close of the macula now. Those microaneurysms are outpouchings of capillaries, and if you remember, when there's cellular damage on the vascular system, those microaneurysms are going to leak. They start to leak fluid into the layers of the retina, and that's where we'll start to see swelling. If it's close to the macula or in the macula, the swelling will lead to macular edema. So you might see that documented in our clinical exam as macular edema, or more specifically, diabetic macular edema. So if you remember from our capillary, if we have that outpouching or microaneurysm, MA, as the red blood cells flow through it, some of that fluid starts to circulate and spin around in that aneurysm. And the pressure difference, because there's a weakened wall, the proteins, the fluid will all start to leak out into the tissue. And we'll start to see things accumulate in the macula, like hard exudates. Those are accumulations of proteins that are starting to leak. Interestingly, wherever the source of that is, sometimes we'll see one microaneurysm, and there's a ring of hard exudates around it. That's because as the fluid seeps into the tissue of the retina, the hard exudates will start to accumulate at the edge of that fluid. So we call that circinate hard exudates. Meaning, probably in the middle of that ring, there's probably one focal point of leakage. This is a little bit more specific term, so not just non-proliferative diabetic retinopathy. We also now have, or with, remember the Latin word con, with macular edema. So diabetic macular edema or macular edema. Diabetes with macular edema, now we have to decide, is this vision threatening or not? So that's where you'll see the word clinically significant macular edema, and there's specific criteria for that, which you can look up the definition. So if it is clinically significant, or if it is vision threatening, or if it maybe already is, let's say their vision is already suffering because the fluid is now into the fovea, now we start to treat. And at this stage, there's two treatment options. Either, which is what we normally do, either we do intravitreal injections, intravitreal treatment, such as Avastin, or Eylea, or Lucentis, or even some of the steroids. And the way that works is we block the VEGF. By blocking VEGF, we're able to stabilize the leaky blood vessel and reduce the amount of fluid extravasation into the tissue. The other treatment is with laser, and the laser we can kind of break down into two specifics. One is called a focal laser or macular laser, and two techniques for that. Focal laser can either you can physically target the singular microaneurysm and zap it. Once we zap that microaneurysm, we're with the laser coagulating it, causing it to occlude. Or you can use the focal laser in a grid pattern wherever it's swollen, and the grid pattern will help reduce the swelling. So focal laser or a grid laser is the treatment for this CSME, macular edema. Okay, so going back to this part, when the microaneurysms get too large with Furchow's triad, they start to burst, and if they burst, we end up with the dot blot hemorrhages, the flame hemorrhages, and that's where we'll see, like on our exam, we'll see these flames and we'll see these dots, these bigger dots. They're not a microaneurysm, they're actually a physical dot of blood that entered. But over time, if enough of the capillaries begin to burst, there's capillary occlusion. And when enough of the capillaries occlude, that is going to lead to ischemia. So that enters into our next phase of diabetic retinopathy when it becomes retinal ischemia phase. So I'm going to erase this section so we have more room to talk about the progression. So if we have enough of the capillaries dying off, we have the microaneurysms, and let's say several of the capillaries in this one section become ischemic. Broad fields of retina now have no oxygen because the capillaries are occluded. This section of retina is going to now increase the production of vascular endothelial growth factor. These are the ischemic factors that say to the body, hey, we don't have enough oxygen, we're starving here, send us help. Increased VEGF is going to lead to more leaky blood vessels, more macular edema, and it's also going to all of a sudden recruit new blood vessels. So increased VEGF, now we're going to recruit blood vessels. New vessels. Now all of a sudden the body says, okay, so you need more oxygen, we're going to send you more blood vessels, but you think that's a good thing. It's not, because the new blood vessels aren't normal. They are abnormal blood vessels. So we call that neovascularization, NV for short, neovascularization. And you're going to see this documented on the examination, either on the nerve. If it's on the nerve, it's called neovascularization of the disc. That's NVD. So if it's anywhere around the nerve, that's called NVD. If it's anywhere outside of that, we're going to say, let's say it grows over here, it'll look like a Medusa head, and we call that NV, do you know the word? NVE. That means elsewhere. So either on the nerve or anywhere else, that's neovascularization. These are the neovascularization. One more place that it can happen, and if you remember from our other lecture about documentation, on the side view of the eye, it can also grow neovascularization on the iris, or neovascularization in the angle, NVI, NVA. That means it's so ischemic, so bad, that even the anterior structures of the eye are showing signs of the increased VEGF, and they are trying to compensate for it with more blood vessels. This stage, the moment we start to see any NV, whether it's on the disc or on the elsewhere, we call this the proliferative stage. So now you know the difference between non-proliferative and proliferative. The main thing is there neovascularization? If you see this, we know there's ischemia, that we know there's enough capillary loss that the eye is now starving for oxygen. Proliferative, like the word implies, means there's proliferation, or there's neovascularization of new blood vessels. Now, the moment you see this is now crisis mode for the eye, because these blood vessels are very fragile, and unfortunately they have the tendency to break open and bleed. So if it breaks here, or if it breaks here, or if it breaks here, if these abnormal blood vessels break, now we're going to start seeing hemorrhage. And there are different areas of hemorrhage that we see. You can see hemorrhage in the vitreous. We would call that vitreous hemorrhage. You can see the hemorrhage in between the retina and the vitreous face. We would call that a pre-retinal hemorrhage. It will look like this. It usually has a classic boat shape to it, because gravity will layer down, and it'll look like a red sailboat shape. If it's so bad that there's neovascularization of the iris or angle, you will see a hemorrhage in the front of the eye in the form of hyphema. So when we start to see proliferative retinopathy with hemorrhage, this is a serious concern, because there's a huge risk that these patients will have severe vision loss very rapidly. And these are the stages that we treat with some of the main things, like we did for the non-proliferative. We use intravitreal treatment with the injections, which, as you know, works along the anti-VEGF pathway or the inflammatory pathway in the case of steroids. And we also treat with laser. Now, there's a very specific laser we do for this. We can, like we did before, because a lot of these patients also have macular edema, we can do the focal laser treatment to the macula here. But more specifically, we do a laser called PRP. That stands for pan-retinal photocoagulation. So in these cases, there's huge segments of the retina that are absent any blood flow, absent any capillary circulation. And so with PRP, we are taking our laser and we are coagulating. We're killing off the edges of the retina. And by doing so, we're destroying the ischemic sections of the eye, hopefully in a process to reduce our overall burden and reduce our overall production of VEGF. Maybe an analogy would be if you have a patient with a gangrenous foot that doesn't work anyway, it's ischemic, we amputate the leg so as to save the whole body. Well, in this case, we are destroying with a laser parts of the retina to save the rest of it. And if you remember, the most important part of vision is the macula. So we keep that part. We use the PRP on the edges so as to save the center. Sacrifice the periphery so as to save the center. Downside to PRP is a lot of people notice nighttime vision gets worse, which makes sense. We've destroyed part of the retina. And sometimes if there's very aggressive PRP performed, there is peripheral vision loss with a constricted visual field. So let's say we didn't get to the patient in time. Or let's say their disease is so aggressive that lots of vitreous hemorrhage forms, lots of preretinal hemorrhages form. And now this goes into the final stage of diabetes when it gets really bad. We start to see the blood scar, we start to see gliosis and scarring, and then that is the final stage here called the tractional stage. Traction means there's so much blood, and as the blood begins to resolve, the scar tissue forms, and the scar tissue begins to contract and pull, and eventually leads to retinal detachments. So when we get to these final stages, we don't just do lasers and injections, we start to do surgeries, pars plana vitrectomy. So you physically go in there, you vacuum out blood, or you aspirate it, you remove the vitreous, you do more laser, and you try to salvage the eye before we have a complete tractional retinal detachment, a funnel detachment, and that's the end stage of this. So in that normal progression, when we start to see this stage, the PDR, proliferative diabetic retinopathy stage, we really start to treat more aggressively because untreated, it leads to severe vision loss, blindness. One more thing that can happen if it gets to this stage, the NVI, NVA leads to a very specific form of glaucoma called neovascular glaucoma, and that is a whole topic on itself. Very aggressive form of glaucoma. So I hope this helps. It will explain the pathophysiology in a broad sense about diabetic staging and also the treatment and why we do specific treatments in each stage. Was there any questions on that? Okay. As I upload this, I'll try to, maybe I can snapshot some of the maybe clinical photographs of this, so when you rewatch the overview, you can kind of see some actual pictures of it instead of just my sketches here. And it's pretty good. In 20 minutes, we did it. If you find this lecture useful and are looking towards more information about other general topics in ophthalmology, whether you're a student learning about it or a technologist, then click on this playlist where we go over more lectures and topics of ophthalmology.